Greetings, I'm Manuel Galvão. It is a pleasure to be among you today. I wanted to thank you very much, Professor Melka, for this invitation. And the idea is to talk about bariatric endoscopy. Is one of the matters that I like the most. And with no further, he asked me to talk to you about what I think that is the state of the art. So to begin with, we should understand obesity is a chronic disease. So this is one of the slides I like the most. It's from the American Gastroenterological Association. Was the front page, the cover page of the very first edition fully dedicated to obesity. And if you can see here, divide like a clock, you go to 12 o'clock and you go clockwise. We have to assess obesity, understand obesity individually to each patient, and then after intervene in it. I'm telling you about clinical treatment, endoscopic treatment, surgical treatment, wherever treatment intervention in obesity have to be like this, and it will be followed after 6 o'clock by not the struggle, but the concern on maintaining the weight loss achieved with the intervention, because it will in any ways get to 9 o'clock, and 9 o'clock to 12 o'clock is that we have to battle to prevent weight regain. And so it doesn't matter what kind of intervention we do or we did in obesity, they will follow this round circle here. And to us, bariatric endoscopy is between bariatric surgery and in clinical treatment. And you can see here this graph from Brahma Budaye in terms of efficacy and refuse of the patient. So everybody accepts clinical treatment, intervention, behavior modification, medicine. When it comes to intervention in a more obese patient, more severe obese patient, there's a trend to refusal. And our vision is that endoscopy could fulfill this gap. And also if we mix and we enhance that with the new medications, it really can go and move forward. If you see chronic disease models like orthopedic cardiology, they always have an intervention on the middle that you can see in the cardiology, you get the mainstream that is the endovascular. So in our situation, we have the initial and we have the end, and we don't have a middle option that we think the endoscopy can fulfill that, ending up in having in between, as I stated before, clinical and treatment, surgical treatment interfacing with both. So what we have to offer 2020 in terms of endobariatric therapy. So you're seeing on the screen interventions on the stomach, and we can put the device that occupies space in the stomach, occupies space in between the stomach and duodenum. We can modify the anatomy of the stomach and its body, modify the anatomy of the stomach on this fundus and antron, and even part of what the patient ingests, we can take it out. And you can see here, they're all FDA approved, meaning they are available for clinical use. Also, like surgery, we have interventions on the bowel. And we can detour the path of the food by means of sleeves. We can detour the path of the food by doing magnetic anastomosis, or we can go even further in altering the internal anatomy of the organ by like ablating the mucosa of a part of the bowel. That said, as surgery has interventions on the stomach, interventions on the bowel, our interventions on the bowel, they are still experimental, and we discuss over the next slides. So let's start with the oldest one. So more than 20 years, we have the space occupying device, intragastric balloon, that basically you pass something through the mouth, through the esophagus, getting to the stomach. So you're gonna inflate that with air, with liquid that's more frequently, or even gas like nitrogen. You leave it there for a while, it fulfills its mission, 6 months, 4 months, 6 months, 1 year. And most of the time you have to puncture that, empty and remove, or like the new ones, they're just gonna pass without the need of endoscopy. But basically, it's what you just saw on this cartoon. And these are the devices that we have now. The FDA approved from left to right on the upper. You're gonna see here the traditional one. This is liquid filled between 400 and 700 liquids. Most of the times with methylene blue saline solution, stays for 6 months, for 1 year. And then we have those small balloons. They are fulfilled with nitrogen. They last around 4 months. They are ingested or swallowed more properly, but they have to be removed by endoscopy. And then you have this one on the right that occupies space in between the stomach and duodenum, like with intermittent pyloric obstruction. Those are FDA approved. The bottom ones, you see, they're under FDA study, meaning they already finished the study, they submitted, and they're waiting for the results or the approval from the FDA. So inferior left, you have the adjustable balloon. You see a tail on this balloon. So after you implant, you can go there with endoscopy, grab the tail, take out by the mouth, and up adjust or down adjust it. And this more newer one, inferior right, it is the one that you just swallow. No need for endoscopy to put it in, no need to endoscopy to take it out. Why? Because after a patient ingested, you do an X-ray, you confirm the position, you fulfill that with 550 cc's of a suturing proprietary solution. And after 4 months, this white spot you see on the balloon is not the valve, is a specially designed spot that this suturing acid solution will corrode it. And then after 4 months, it will empty the balloon, and the balloon is making a small and thin film. It will pass through the bowel. So this is what we have right now. It is silicone, so you can have copies of those balloons all over the world, especially the very first one I mentioned. And let's see about the results. So only targeting FDA studies. So this is a recent review that we published. And you can see here there are the FDA studies, or at least prospective randomized control. And you can see here on the middle, the percentage of total weight loss. It comes as newer is the balloon, better is the design of the trial. So better is the weight loss. You see the adjustable balloon with almost 15%, and then comes the traditional balloon with 10%, and then the dual balloon that doesn't exist anymore, the one that you swallow fulfilled by air, and both the swallowable, fully swallowable balloon, and in another one, they don't have available yet the results. But you can see here between 7 to 14%, and 7 are the balloons that really use it the least. So how about meta-analysis? So like this from São Paulo University 2020 is a meta-analysis, gentlemen, of about only prospective randomized controlled trials. And you can see here the controlled trials that we have, different types of balloons. And you can see by each balloon, if you go to the right and you see the losango of the meta-analysis, you're going to see here that always benefit balloon to the right, benefit the balloon to the left, it benefits the control group. So this is a very strong evidence that the balloons work. And also, some of our studies dictates the clinical practice, and you can see the one that we published, the Brazilian consensus, with more than 40,000 balloons. And just as the summary of that, 41,000 balloons, 18% of total weight loss, 2.5% of severe adverse events, most common hyperinflation, spontaneous deflation, early removal rates of 2%, and a mortality of just 3 patients out of 40K. So it's really, really safe. And that study has a bias, and it's a positive bias. It was done by Centers of Excellence that only deals with the bariatric endoscopy. So that's why you have this like a very optimistic and good results. But also, balloons, not just a weight loss. So recently, FDA approved one indication for balloons that to treat the fatty liver, NASH, on that. And you can see on the upper right on this study from Mayo Clinic that the steatosis, the ballooning of the cells, and inflammation always goes down, as well as an NAS score, that is the fatty liver scores. And fibrosis, as you can see here down on the right, doesn't influence, it doesn't have to on that. So that's another indication. And we are really getting on like refining the indication on that when we study gastric emptying. As you can see here on the right, the early removal rate in terms of gastric emptying, the ones patients that get with the slow gastric emptying from the beginning tends to reject more the balloon, and also they tend to lose less weight, as you can see here. So we are guiding the weight to refining the indications. Balloons are the oldest in the bariatherapy. They are here to stay, and they're always going to have his space. So 20 years, the market, 10 to 12% of total weight loss, they are safe. 6 months, 1 year, more than 600 cases done worldwide. And then comes the endoscopic gastroplasty. It's newer, so it's a way that we're gonna remodel the anatomy of the stomach, try to tubulize that on the body by means of this machine, and we go directly on the anterior wall, greater curvature, posterior wall, and do a lot of, or some different suture patterns. But basically what the idea is to like alters the anatomy, tubulizing or shrinking the body of the stomach, as you can see here on this cartoon. So it's pretty much very standardized. You have this grasper, helix grasper, that you pull the tissue inside, and then you have a gigantic needle holder that you have this double channel, and you pass the needle from one side to another as some of the laparoscopic device. And you can see here that the movements are pretty much standardized on that. And what we achieve, you can see here intraoperative tomography. This is the idea. We shrink the body, and you can see here that with more details in a 3D rotation. Also another one, a more graphic design. We keep the fundus. Is very different from the sleeve gastrectomy that they have to take out the fundus. Here is different. And even on this X-ray, that's very beautiful X-ray that looks like a sleeve gastrectomy. It is not. If you pay attention, they have a gastric bubble on the fundus. And this is just to show you just after a procedure. So you can see here the antrum that we don't do. You see the incisura, and you can see here the tubulization of the stomach. We can shrink as much as we can, but in general, most of us, we don't do that much. We don't pursue to have a tube like sleeve gastrectomy, but you can see here that definitely we alter the anatomy of the stomach. Very different from sleeve gastrectomy. You can see here the dynamic MRI from Mayo Clinic from Professor Aboudaye, and you see the heart beating, and below the heart, you see the stomach, and the stomach is moving. We don't take the attachments, we don't take the vessels. So the stomach still keep the capacity of relaxing. So it keeps its environment of being low pressure, high compliance, very different from sleeve gastrectomy that is high pressure, low compliance system on that. And this is a brief history of this device. We start in 2012, and you can see here 13, 14, first series, and then just now on 16, 17, we have the big series of 1,000 cases coming from Saudi Arabia, as well as we are producing level 1 evidence in US with a randomized controlled trial. And this year, our group published the Brazilian consensus with a considerable amount of patients, 1,828 patients with 18.2% of not the excess weight loss, but total weight loss. So that's wrong. We have to correct that. So more than 70 papers done up to now. We're going to track the literature by our published experience. So this is one of the Brazilian publications in surgical endoscopy, starting with 219 cases and patients eligible to be followed at 12 months, 123. You can see here 19.7% of total body weight loss with no mortality and one adverse event, a bleeding that was corrected by clipping. With endoscopic clipping. You can see here the total weight loss, how it goes, and you can see that each of one of these blue circles is a patient. It works like an error bar, and you can see here they're very concentrated on the middle. I mean, they're very kind of predictable. And then comes our Brazilian consensus. These are colleagues that work with us, as I state, 18.2% of total body weight loss percentually. This is the colleagues, all the colleagues of these collaborative groups, 47 endoscopy, 15 years of experience, a mean of 87 per participant, all training standardized fashion designed by us in a U-shaped suture pattern. You can see here, this is the U-shape that we use. And also we recently add the square shape that is a tendency on this group to use that more recently on that. So that's very important on that amount of patient, the rate of complication less than 1%, hematemesis or bleeding, 7 patients, prolonged pain due to CO2, persistent vomiting, respiratory insufficiency, and the most important, 3 patients needs laparoscopic intervention to abscess and one gallbladder puncture. And for the first time among all the more than 70 papers, there is the first published mortality, and it's due to pulmonary embolism up to 2 weeks after the procedure. And there was a very ill patient that was evaluated by a group of surgeons and gastroenterologists that decided to pursue on the direction of endoscopic sleeve gastroplasty. So that's I'll go fast with that. We have achieved consensus in a lot of care, quality of care, indication, contraindications. You can see our target is 30 to 35, but we don't have upper limits, inferior limits 27, and preparations like surgery. Technique is something very endoscopic, 4 to 6 sutures, U pattern, and main goal is to reduce the gastric curvature on that. And then we got this very recent, since September 30 to 2020, publications of Cornell of 5-year follow-up on those patients. And let's see here, 203 patients at 5 years, they have 89% follow-up of the 30+ patient that was eligible to be followed, meaning that the one that reached those 5 years. Weight loss of 18.7, percentage of total weight loss, a mean of 14.5, and 69% of the patient with at least 10% of total body weight loss. 2 upper GI bleedings, 1 perigastric collection, so no mortality, and keep the safety profile. You can see here the weight loss. Interesting thing to see that it was very predictable, like 48, and then it dropped to 60, possibly by the fewer patient that was followed by 5 years. And how it compares with surgery. If you compare endoscopic sleeve gastroplasty versus gastric plication versus sleeve gastrectomy at 2 years, that was recently published this year, you can see here that the endoscopy technique has lower weight loss, but it's a very good one of 18.5%. That's 2 years when compared with laparoscopic sleeve gastroplasty and laparoscopic gastroplasty on that. The trade-off is the safety. You can see here that endoscopy is safer than, statistically significantly safer than surgery, and also patient stays for less days in the hospital, as you can see here by your own eyes. And also meta-analysis. There is at least 11 meta-analysis published. This one from our group published, and you can see here down below, just follow the losango, the red losango, up to 24 years, 24 months. You see here that is always over 15% of total weight loss. And then you have this also very recently for this year, a meta-analysis of São Paulo University that they are specializing in analyzing some other else work. But like see here, the papers evaluated, and also you can see here on the graph that is presented total weight loss and assessed weight loss. So you can see here up to 70% assessed weight loss in 18 months and 16% of total weight loss in a meta-analysis. Very well done. And we will end with this FDA trial to produce level 1 data. Mayo Clinic, Cornell, University of Texas, Harvard, Hopkins, and more private centers. And there's about to produce that. So we have 8 years of these techniques, 15 to 20% of total weight loss. It's safe. Between 1 and 3 years is approved, and it's around 15,000 cases done worldwide. The other option over the stomach is the pose. It uses a proprietary solution, very sophisticated, to build up a fold, a very durable fold. And this is how it's done. And you can see here, you use this helix. Then you have this jaws. Over the jaws, you pass a needle, and you're gonna have one basket in one side, the other basket in the other side. Then you put them together and cut it. So that's how it is built. And you can see here, Professor Gotran Lopes Nava, and it's non-edited. You can see here, you grab the tissue with the helix, you pull the tissue inside. And after that, you're gonna open up the jaws of the device, pull the tissue. It's a 6.2 centimeter bite, so very big fold. Put one basket on one side, the other basket in the other side. Then they put them together, as you can see, about to see here. Then they cut, and you go to another one. So this was the first design, POSE 1.0. They do the fundus, they do the antrum. Very good results on Europe, even on this randomized control trial, as you can see here, in between green for the intervention and blue, the diets. So a very interesting difference. And but unfortunately, when they went to the to US to do the FDA trial, by study design, they couldn't pass over 5% of total weight loss, and the study was not approved to be used in the clinical practice. And on that direction, as we thought before, that there was a new procedure design, the POSE 2.0, and this procedure is about forgetting about the fundus, forget about the entrance. So you go in the body and you do semi rings on the greater curvature, horizontal, and vertical ones. So that's the idea, to go there and do this design. And at the end, we want to achieve a shrinking and a tubulizing of the greater curvature. And you can see here and compare how it is. So the group has just published the very first technique. And also in DDW, we published the first European pilot study. You can see here 41 patients with 17.5% of total body weight loss at 9 months, and 91% of the patients reaching at least 10%. No serious adverse events was recorded on that. And there is, just to see, is one of the first patients that reached 2 years. Is a very beautiful X-ray. And currently, Professor Boudaye is about to begin a new POSE with this technique, POSE 2.0 FDA study. So 2 years on POSE 2.0. The POSE 1.0, that's much more, like 10 years. 15 to 20% of total weight loss, safe, experimental, but approved to clinical use in countries in Europe like Spain and Italy. There's another methods of sutures like this one that's called Endomina, that was developed in Belgium, and we're just gonna show you how it works. Use a regular scope that you put a guide wire, then you slide the device. It's very interesting device. Then you open the device, pass the scope, grab the tissue, like POSE, pass a needle from one side to another, but just on the other side, you left an anchor, and you are able to grab another bite on the other side, and then you can pull them inside the scope and do the sizing of the stomach, as you can see here. So they just published one paper, and this paper with 11 patients, at the end of 6 months, they have 11% of total total weight loss. And also this very interesting one that just published in 2020 by Bertrand Lopez Nava group in Spain, that's called Endoscopic. The idea is to we'll aspirate the anterior and the posterior wall and have an automated needle with a suture that will go around, and we'll get like a Mason gastroplasty at the end. So it's a very, very interesting way to think about it. So they did in 11 patients, they have a very interesting result of 16% of total weight loss, 54% of excess weight loss at the end of 6 months. So we have to see what those techniques going to bring to us. And in terms of metabolic endoscopy, what can we offer? So the first one is the thermal duodenomucosal ablation, how it's done. So you do an endoscopy, you identify the papilla, you tattoo the papilla on the other side, or put a clip, then you go to the triangle, you put a guide wire. Over this guide wire, you will slide a balloon. This balloon touches in 3 points, aspirate the mucosa, and inject methylene blue saline solution, making a 360-degree lifting. And after that, you progress to another lifting. And then inside this balloon, you have circulating hot water. So you go up to 87 degrees for 10 seconds. And then you progress again, lift, ablate, lift, ablate. So your intention is to ablate 10 centimeters of the mucosa. And then you remove the device, patient can go home. You see here how it is. So we follow the path. We published the first in human study. This is just you to understand how it is. It's done in our service, one of the trials, endoscopy and X-ray, how it goes, this balloon inside the lumen. And then you can see here just after how it is. So it's a lot of damage on the mucosa, as you can see here, and how it is after 1 year. So it's completely healed on that direction. First study published on diabetes care, and also another study published in gut from single series, multicentric from South America, and South America together with Europe as well. So you see here's a drop of around 1 point of A1C that it seems to be steady up to 12 months. And also if you go inferior left right quadrant, you see that there's really dramatic drop on the LET, meaning improvement on the fatty liver. It's not for weight loss, patients lose minimum weight. You can see here as more blue, you have on the screen less fat. So compare from the left to right, there's an hepatic MRI with good results in terms of that. So we already are progressing in terms of prospective randomized control trials. So look, this one done between Brazil and Europe. And you can see here on green, the DMR group, and in gray, the sham. You can see the statistical difference between the groups of around 1% drop of A1C. And also this one is about comparing the intervention group with the sham group in terms of improvement on the fatty liver NASH on that. Again, the same, and also some studies like we are going to more severe ill patients depending on insulin, that we are able to keep out the insulin. So currently, Professor Thompson from Harvard are leading the FDA's trial, so we have to wait for the results. 5 years we're doing that, not for weight loss, a drop of 1.2, 1.4 A1C, safe, experimental. We are waiting for the FDA study. Also have this one, duodenojejunal gastric bypass with GI sleeve, that basically you do an endoscopy, guide wire, slide a capsule, inside this capsule like a parachute, you have the sleeve, 2 feet, 6 centimeter sleeve with a automatic ball on the tip that when you end, you leave the ball there. Then you're gonna open up a stent in a post-caloric situation that has barbs to keep it in place. And the idea is that you're going to see now that the food in yellow will pass through the lumen of the sleeve, and the biliopancreatic juice will pass around like the biliopancreatic limb of a classic gastric bypass. At the end of 1 year, you go there with a customized hood, customized grasper, and you're going to get inside the duodenum, you're going to grab the suture, collapse, and take it out. So that's the idea. How it works. So this very interesting graph you see here on the inferior left quadrant are patients that effectively lose weight and drop A1C. The upper left quadrant are patients that just drop the A1C. The superior right quadrant are patients that have no response, and the inferior right quadrant is the ones who just lose weight. So this how it works. Patients lose weight and effective drop the H1C. The studies up to 1 year, you see, it's just the weight loss, or total body weight loss percentage. The 2 studies that reach 1 year, it's more than 15% of total weight loss. And among 40 papers done over this device, and even this one, it's a meta-analysis done by the ESGE, it's called PIVI. And you can see here on the papers published, if you go to the meta-analysis, it's very interesting on that. On the bottom, you're going to see 0. To the left is a drop on H1C. To the right is an increase of H1C. So all the studies points to a drop of around 1.5 H1C or more. Even those 3 studies, that they are prospective randomized control study. Again, you see down below on the horizontal line, you see 0. And then you see a drop of H1C for the losango of the meta-analysis of 1.5. Unfortunately, it went to the United States and it fails not for efficacy, but for safety. Because what is the reason is that different from what we find in Europe, in Germany, in Latin America, they have a rate of hepatic abscess that was much more higher than we expect. So we can see here the study was stopped at 1/3 of the patients, but again, you see here in blue the patients that have the device, in red the sham patients. Inferior left quadrant are the ones who lost weight and effectively dropped the H1C. So even with a third, it could demonstrate the super superiority, and it warranties when they went to FDA, they get another chance, not for 1 month, but 9 months, and we have to wait for the results. So 10 years that we are studying that, up to 15% of total weight loss, a drop of 1.5 to 2% of H1C. It is safe. We saw that it was safe, but we saw that maybe not that much. Still experimental. We are waiting for the FDA study to do. And then we have this last one, that's the junoilial bypass, and it's done in a way that we're going to create magnetic anastomosis. How? We do a colonoscopy, then we intubate the ileum, then we pass on scope, upper scope, a pediatric colonoscope. We got 40 centimeters after the triangle. We got to a drop zone, transillumination, X-ray, see where we are, and then inside the scope, the working channel, we have very sophisticated magnets, and you're gonna see here they will open up and they will close on an octagon shape. They have 3 sutures in each one of them, and you have joysticks outside that you can control them in a line with X-ray, and then we let them go. The magnetic force will act. After that, you cut. And the idea is around 7 days, we'll compress and you pass through the bowel by creating a side-to-side anastomosis, as you can clearly see here on the cartoon. So there's one paper published from Czech Republic, our friend Evsen Machika, 10 patients with obesity, and most of them with diabetes or prediabetes. Just follow the track of this is the fasting glucose reduction and up to 1 month. And also the weight loss, you can see in light yellow, 14.6% of total weight loss. So all of those patients were followed by 3 years, and at the end of the 3 years, they reached 18% of total weight loss with 1.8 drop of H1C. But at the end of 1 year, one patient had internal hernia. You can see here on the left, the endoscopy and how the magnet is getting out and being formed. And by study design, the protocol demands to have a laparoscope to assess safety, but look at when the coupling of the magnets got it, how strong they are. And on this next one, what you're about to see is that on the left side, you're going to see 3 lumens, but you're not going to be able to identify where is the anastomosis, because that's really, really beautiful anastomosis with no inflammation. As you can see on the right side, the side-to-side nature of that highlighted by the X-ray. And then went to Argentina to a prospective randomized control trial on that, and we are able to do the cases. A team were happy, but at the end of the day, you need 4 of the most experienced endoscopists in the world, 4 hours of procedure. So everybody decided to get back to the bench. We designed the approach, and now the approach is laparoendoscopic. So we start with endoscopy, 250 from ileocecal valve, get a bowel, then go there to the duodenum, and by endoscopy, you drop a magnet on the duodenum, then you puncture, a small puncture on the bowel, and you open up a magnet. And recently we modified that to cover this opening with the magnets. So what you do after, you put them the magnets to couple. So the magnetic force will go on that, and the patient go home next day. So you can see here the very first images of that, coupling the magnets here, as you can see here also by X-ray. And the patients are doing great. So the initial 5 patients before the pandemic, and then now after the pandemic passed, we're gonna start, we'll resume possibly by the end of the year. And now there is centers in Europe, in Barcelona, there are centers in US, and FDA got a very positive review of this device. So I think that those anastomosis, magnetic anastomosis, are gonna see all over the abdomen in the near future. We have 3 years, up to 18% of total weight loss in between 1.5 and 2%, safe experimental in its infancy. In near future, what we're gonna see is it is the junction of intervention on the stomach with the bowel in endobariatrics and with also drugs, and getting to a point that we will have repeatable endobariatric therapies that can be combinable, sequential, enhanced, and can be go in the direction of be personalized procedure. This is a very new one. We just finished the small animal studies. It have a balloon and have a sleeve. And maybe even we can get on other direction like endorobotics that we start with this company in US. So we get passed through all the phases. We just finished the animal studies in Brazil, as you can see here. We start in the column, but we already have a prototype for the upper ready. And we will really about to begin and get on the frontier that we can see here, that we will be able to suturing with very, like, if I can say, surgical actions. And it's like a full robotic system that we are about to do the very first in man. You can see here the animal work that we have done and the suturing line that we are able to achieve. So are we effective? Yes. Are we safe? Yes. Do we less? Yes, but not a surgery, and it's not our intention to be like surgery. Do you need to less? It depends if you consider obesity as a chronic, progressive, incurable disease. We don't need to less. Our procedures, some are reversible, some not, but definitely they are all upgradable. If you need surgery, you're not going to burn bridges. And ending with this picture of Texas Heart Institute open heart surgery 70s. And then you go to 2000s, and you're going to see here the interest that we raise over these techniques. So I want to thank you very much for the invitation, and I hope we have a very fruitful discussion from now on.